An honor to me present the next host is Dr. Philip is a radiation clinical oncologist from UK. He's based in Oxford, and he specializes in GU tumors. Thank you, Philip.
Good afternoon, everyone. Thank you, Vlad. I'm Philip Camilleri, and I'm delighted to be here this afternoon. I'm very conscious that this session stands between us here and a nice drink outside on the terrace. The birds are singing. It's a nice evening. So I think without further ado, we'll get on. We have 4 very interesting talks today, a lot of interesting ground to cover, international speakers as well. So our first presenter is Dr. Dan Ford. He's a leading UK radiation oncologist who works with us in GenesisCare UK. He's a core member of our MR Linac team in Oxford, and also part of the GenesisCare National Urology Clinical Reference Group. And Dan is going to take us through the use of MR Linac in prostate cancers. And then Dan, you'll join us later for live Q&A. Thank you.
Thank you, Philip. Apologies that I'm keeping you from your drinks. Welcome from a not so sunny Birmingham in the UK, where it's just starting to rain. So if I can take you through the nice slides, I'm going to talk about the MR Linac in a clinical setting and what we've been doing in the UK. I'm going to have to ask for the next slide, if that's okay. So, just as a way as a background, and I'm sure a lot of you know this, but the MRIdian and GenesisCare in the UK has been quite an interesting story. It was first brought to the UK by GenesisCare in 2019, initially in Oxford, and then recently in the last year, a second centre has opened at Cromwell in London. As I'm sure you know, we treat a range of extracranial sites. And with all of the sites, although there are different sites that are treated, there's the same policy and structure for all of these, in that all fractions are replanned by an on-site consultant, and each plan is re-optimized. And so on both sites, usually on each day, you have 2 consultants of mixed site specialties. However, all of those site specialty consultants will replan every single thing that's on the MR Linac that day. So although I'm a uro-oncology clinical oncologist, if it's a pancreas or something like that, I will be replanning that, and vice versa. It's not just for those consultants who are actually on the MR Linac that day or who are a part of the GenesisCare team there. Other consultants from all around the country can treat their patients on the machine and can treat them remotely in terms of planning, and then allowing the consultants who are there on site to treat them. And all of these consultants will, if they are keen to do that, will go under a relatively detailed credentialing process, so that they come down, they look, and they have a number of cases that they have to plan and show that they can do that to the appropriate level before they are allowed to treat their patients there. What you'll find is that every single patient that is treated, prostate and anything else, all plans are peer reviewed by a second consultant, and that's usually of the clinical reference group that does that. Certainly, this is something that we are moving towards in the UK in every area of clinical oncology and radiotherapy, but it's good to make sure that that's all done up front on the patients on the MR Linac. So next slide, please. So with regards to prostate, so far of the 2 sites, we've treated over 170 prostates, which makes up about 1/3 of the overall workload of the 2 centres. As I say, all of these cases are initially reviewed by the local urology MDT group, and then they are reviewed by the clinical reference group, which there are 5 members of ourselves. We have certain criteria about whether or not they can be treated on the MR Linac. As I said, all of the plans are then subsequently peer reviewed, and then the treatment proceeds from that point. And certainly the majority of our cases have been what I would call a standard fractionation of 36.25 gray in 5 fractions, treating on alternate days. And part of the real commitment from GenesisCare for this, and certainly for the prostates, is to develop a comprehensive patient-reported outcome system for this and side effect profile, as clearly that's one of the significant benefits of treatment on the MR Linac. So can I have the next slide, please? So what are those criteria? And they're the inclusion criteria are really what you'd expect. So over 18, a good performance status, and a biopsy-proven prostate cancer from Gleason 6 or above. From a staging point of view, we treat up to T3A and B, but they obviously have to be defined well on MR Linac. The majority of these patients have had staging scans with PSMA PET scans as well pre-treatment. We have a criteria of the volume being under 90 cc on the MRI scan, and an IPSS score of 19 or under out of 35. Obviously, there are some other criteria that the patient needs to fulfill in order to have treatment, such as being able to have an MRI scan, and also not to be too claustrophobic. We're not treating anyone who's got any sort of metastatic disease. Patients are allowed to have a TURP, but we do encourage that there needs to be an 8-week gap at least from TURP to actual treatment, and obviously reassessment of the IPSS following that. Next slide, please. So I have to say, what I'm often asked when I say that I treat prostates on the MR Linac is, what's the use of treating a prostate on an MR Linac? There's clearly a lot of interest in other areas such as pancreas and liver, and treating things that you can't really treat on normal linear accelerators. But we know that you can treat prostates well with good outcomes and good quality of life and side effect profiles with normal linear accelerators and other things. So what's the rationale for it? And I should say that I also have treated a number of cases of prostates on other systems such as CyberKnife, which I've done for a number of years, and also I treat a lot of SAVOR patients generally anyway. So I've got a good access to different machines. But I do think that actually with prostate, it's what I always say is, once you've seen it, you can't unsee it. And there are a number of reasons why I think the MR Linac is really stands out above these other systems. First thing is obviously target delineation. You are planning your prostate on an MRI scan, so you can see you're not using a substitute or a fused MRI scan. You are using what you can see, and so it's very useful to actually be able to do that. However good an MRI fusion is on a CT planning scan, it's never perfect, and so certainly actually planning on the MRI scan, I think, is a real step forward. I think the other thing that is very obvious when you look at these plans and you look at the prostates is actually how much the prostate changes between the plan and individual fractionations. And so certainly replanning the prostate on a daily basis, particularly things such as the seminal vesicles, makes, I feel, a big difference. And reoptimization of that baseline plan is again something that I will show does make quite a difference. And the third thing is the gating and tracking during the treatment is something that is something that's very useful. And this is an active process. And certainly, as the patient is lying there for sort of 40-45 minutes on treatment, the number of times you see gas moving through the rectum and moving things out and having to stop and let things pass and do things like that is a huge thing in a number of patients. So I think these are all really useful things, and certainly other systems such as CyberKnife, where you're obviously tracking a surrogate in the form of a fiducial marker, is good, but you're not actually, in terms of most initial marker placements and things like that, that's actually within the prostate itself rather than in things such as the seminal vesicles. So I think that it does offer a significant benefit in terms of patients who are treating with prostate cancer. Can I have the next slide, please? So what I was going to do now is just go through a case history of a sort of standard patient that we would treat. So as you'd expect, 74-year-old man, localized disease, intermediate risk PSA and bilateral Gleason 3+4 with a relatively normal sized prostate and reasonable IPSS score. The majority of our patients we will still treat with 4 to 6 months of hormonal therapy, generally with LHRH agonists or occasionally oral biglutamide. Some patients are treated without this, but these tend to be the low to very small intermediate risk patients, but the majority are still being treated with hormonal therapy. And next slide, please. This just shows you the top left is the planning scan, and then the 5 fraction scans of the patient in the axial setting as they've been treated. And I think this demonstrates things quite nicely in terms of how much things do move and how much things do change, with their change in the rectum and where it is, and things such as the seminal vesicles as they move around the rectum itself. So that very nicely demonstrates how things have changed on each 5 days. And next slide, please. And this on the sagittal section again shows the similar plans and how things change on a day-to-day basis. Next slide, please. So this is, again, for those of you who treat on the MRO will be very aware of what this is. So this is the dosimetry for what gets put up once you look at the replanned plan at each fraction, and it's comparing the initial baseline plan with the predicted dosimetry if that plan is delivered on the current plan. And what you'll see is the plan is the one underneath, and the predicted the levels drop, and particularly I'll move you to the right-hand side, which looks at the dose of the rectum. So the dose of the rectum is quite high, and for this fraction is outside of the of what you would generally tolerate for rectal dose for that single fractionation. So what we do is, next slide, please. The computer does its thing and re-optimizes the plan. And again, what you've got here is the predicted at the top and the re-optimized under that. And what you'll see is that the PTV doses all go back up into a high range, and the OAR doses, such as the rectum dose, all come back down back into what would be regarded as the tolerant doses. So what we're really showing here in real time is that actually each fraction does make a difference, and re-optimization can make a huge difference. Clearly, some people more than others, and some fractions more than others, but it certainly can make a huge difference. And so next slide, please. And so here's dosimetry of different plans, and just to show you that, again, that we've shown on the CT scan that there can be quite a change in terms of the dosimetry that's delivered between the baseline plan and the normal plan, or the plan of the day, as it were. Okay, so next slide, please. So how is it? It's all well and good doing a standard 36.25 over 5 fractions. But what you start to do is, as you look at the machine and you see what you can do, you realise the power of it. And so, as you'd expect, we are progressing and doing other things with this. So first thing that raises the question is, do we have to treat daily? Obviously, the data is not always, doesn't say specifically for daily treatment, for alternate day treatments, but certainly it's something that can be done. And we've done a project now with 10 patients whereby we used a rectal spacer, but then treated them on a daily Monday to Friday sequence. We're collecting all of the data with regards to that, but the hope is obviously that is something that we will demonstrate and we'll be able to move into something we can use on a more regular basis. Other things we're doing is obviously dose escalating and in keeping with data, and certainly with the high risk diseases, and things such as the PACE trial, we're using different dose escalation schedules, both 3-dose level as part of the PACE-C and also 2-dose high-risk level with 40 Gray to the CTV and 36.25 to the PTV. And they're things that we're now moving into routine use on patients. I think the last thing that we're certainly is very interesting and something we're really pushing on as well is the idea of reirradiation. Those of us who have treated a lot of prostate cancer patients and seen, unfortunately, a number of them relapse locally, it's very difficult often to give people satisfactory treatments in this scenario. And certainly a lot of salvage therapy, although can be effective from a disease point of view, certainly can cause quite significant morbidity, both in terms of prostatectomy, cryotherapy and things like that. So obviously there's always this idea that you can't reirradiate, but clearly there's progressive data that you can actually do that. And certainly we're moving forward with this, and we've treated a number of patients in this setting, both in terms of the whole gland to any visible lesion, but also a combination of that of the whole gland with a boost to visible lesions. And what we tend to do is we treat again in 5 fractions over alternate days and between 30 and 35 Gray in these cases. So again, we have quite strict eligibility, and you have the next slide, please. With regards to this, the patients go through the same process as the other patients who are first-line treatments. The difference is being that you have to be at least 18 months following primary treatment. Similar staging, but only up to Gleason 8. We do define that you have to have a PSMA PET scan in such settings and biopsy confirmation of disease recurrence. Other criteria, similar, PSA has to be under 20, good performance status, and again, criteria with regards to urinary flow based on IPSS score. Next slide, please. So again, another case study, 72-year-old man, previous T3A, high PSA, radiotherapy 16 years ago, and then subsequent relapse, relatively small prostate volume and clinically very well. Next slide, please. Obviously, the use of PSMA PET and combination with MRI scan and things like that is obviously very useful in terms of defining visible lesions, and this obviously shows that lesion on the scan. Next slide, please. And obviously, what you can then do is mark all your ARs and actual the GTV and use that then to open that up. So next slide, and there's obviously a dose map of that, and this is a plan, and then subsequent is a couple of the days plans whilst while they've been readapted and treated for that patient. Okay, so next slide, please. And again, this just shows you the ability of the MRL to take that base plan and re-optimize that plan so that even in situations such as this where you are reirradiating and clearly doses to things of OARs is crucial, you're able to do that with confidence and deliver high dose treatment in a safe and effective way. Next slide, please. So clearly, again, we always reiterate this, but it's really important, particularly in situations like this, to get patient reported feedback so that we can really have a good idea how patients are doing on this and tolerating this, both during treatment and longer term. Okay, so next slide. So that's me giving you a sort of whistle-stop tour of what we're doing for prostates at the moment on the MR Linac in the UK and on the MRIdian. And I hope that gives you an insight on what we're doing and how we're doing it. Thank you.
Thanks, Dan. I'd be grateful if you could stay with us, and at the end of the session, we'll have a Q&A. We'll move on to our next speaker, who is, I'm delighted to introduce Amar Kishan, who is an assistant professor, vice chair of the Clinical and Translational Research and chief of the Genitourinary Oncology Service for the Department of Radiation Oncology at UCLA. Amar has coordinated and leads on research of SBRT in prostate cancer, and more recently, particularly on MR-guided radiotherapy for prostate cancer. Amar is joining us now live. And Amar, will you be able to stay for Q&A at the end of the session, or have you got?
I will try my best to. It is 7:10 in Los Angeles, about to start my clinic, so okay. I'll try my best.
Okay.
And anyone can feel free to please share my email address. I'll be happy to answer any questions.
That's great.
Wish I could join you for a drink, but maybe next.
Thank you. Amar's going to discuss the results of the MIRAGE trial. Over to you, Amar.
Great. Are you guys seeing my slides? There we go. Okay, so there's numerous theories by which MRI guidance might offer several theoretical advantages over CT-guided radiotherapy in the context of SBRT for prostate cancer. These include the ability to aggressively reduce the planning margins and the ability by virtue of the enhanced imaging capabilities and real-time tracking. So I'll be talking about the MIRAGE trial interim analysis and maybe going a little bit over the logistics, the design of that trial. So it was a single-center randomized trial of patients undergoing SBRT, in which patients were randomized one-to-one to MRI guidance or CT guidance, which in this case with the use of fiducial markers was cone beam CT. So one thing to consider is that PTV margins need to account for motion predominantly, and mainly in terms of motion, it's intra-fraction motion with modern pretreatment IGRT, but also need to account for setup uncertainties. We've done rigorous analyses of CIFs in VMAT-treated SBRT patients, which have suggested that in the AP and SI axes, at least you need 3 millimeters to account for motion that occurs in the span of about a half arc or so a pretty rapid time frame. And that's for motion alone. So you would need more than that to account for the other residual uncertainties that exist. So as a high volume SBRT center for years, our protocol had been to use 4 millimeter isotropic margins. We had been moving towards leveraging a very rapid treatment time using VMAT, 2 arcs or 4 half arcs. That was our standard of care. And I would note that on, say, for example, PACE-B or NRG-TU-005, which are large randomized trials of SBRT for attack prostate cancer, the margin recommendations are generally 5 millimeters, the opposite to reduce to 3 millimeters in the posterior direction. So a 4 millimeter isotropic margin is well within international standards of care as well. So the central hypothesis of the MIRAGE trial was with treatment on the MRIdian, we would be able to reduce the margin significantly to 2 millimeters because of some technological aspects. The first is real-time imaging. You can take 4 frames per second with a CNA MRI. If you place a gating window around the prostate CTV about 3 millimeters and set it such that there's an automatic beam hold of more than 10% of that CTV or region of interest goes outside that gating window, that allows us to, in very granular motion, very granular fashion, really track motion with automatic beam hold. So we felt that could allow us to significantly reduce our PTV. The other thing was that, you just heard about MRI for contouring. This allows us to do a direct MRI to MRI fusion workflow. So we're fusing a 1.5 to 3 Tesla MRI to a 0.35 Tesla MRI for contouring. We don't have the same uncertainties that a CT MRI fusion has. So I want to underscore this because it caused a lot of controversy when the initial results were discussed. This margin difference was a feature, not a bug. That's the point of the trial. The point of the trial is that you can do aggressive margin reduction safely and lead to less toxicity because of the technological advances of the MRIdian or MRI-guided radiotherapy. So the design of this trial was actually a superiority study, and we chose to look at acute grade 2 or greater GU toxicity for practical reasons. This was a single-center randomized trial. As you can imagine, it can be very difficult to do a technology-based randomized trial, and we need to be able to power it adequately so that we can, accrue quickly and get a result. That's why we chose acute toxicity. Toxicity not common. It would have taken an enormous trial to do a power calculation. I'll go over what ended up happening. But that's why we choose GU toxicity. Now, for kind of baseline rates, we extrapolated from PACE-B at a multi-center US trial. Both had PTV doses of 36.25 gray, and we assumed an acute grade 2 or greater GU toxicity of about 29%. And we also extrapolated from the VUMC phase 2 trial that looked at the VURA-based treatments. They used a PTV dose of 36.25 gray as well. They also spared the urethra aggressively down to 32.5 gray and adapted every fraction. So we assumed maybe like a base toxicity there with MRI-guided radiotherapy, about 15% acute GU grade 2 or greater toxicity. So the trial was designed to detect a 14% reduction in acute toxicity. So working out that power calculation, you would need 300 men to provide 83.7% power to detect this difference with a one-sided two-sample Z-test at a 0.025 significance level. Now, there's mounting evidence, including our own data from Memorial Sloan Kettering, that treating to a higher dose, going from 36.25 to 40 gray, is associated with improved biopsy-assessed local control, as well as biochemical recurrence-free survival. So in anticipation of treating a more aggressive disease cohort than on PACE-B, we actually opted for a PTV dose of 40 gray, 36.25 to 40 gray. So that's a substantial dose escalation biologically. Therefore, we anticipated that our toxicity estimates for the power calculation would likely be underestimates, so we pre-specified an interim analysis once 100 patients would be eligible for analysis. So again, just a quick overview of the delivery and planning, because I think there's the main things to know. So the CT-guided arm, 4 millimeter isotropic margins. We did orthogonal images to align to fiducials. Initially, took a cone beam to assess anatomy, repeated planar imaging to align to fiducials after that, and initiated rapid treatment. This was VMAT, 2 arcs, about 2/3 of patients, and 4 arcs, 4 half arcs, let's say, in the other 1/3. There was no interfraction monitoring. We had a very rapid treatment time, 3.4 minutes beam on total. The urethra was defined on T2 axial MRI, so a separate kind of dedicated MRI scanner. We contoured that out and tried to limit hotspots to 42 gray. The MRI arm, 2 millimeter isotropic margins. We actually get the trophy sequence on the ViewRay, the long scan to align to the prostate, select a keyframe for gating. These were all static field IMRT, a median of 15 beams. The CA MRI was obtained, as I've just discussed before, with a gating window of 3 millimeters, 10% reason of interest outside of that allowed. The median beam on time was 12.7 millimeters. Of course, the total treatment time, because of gantry motion, beam hold was substantially longer than that. The urethra was identified on a custom sequence that we've developed at UCLA. We've published on that as a custom haste sequence. I will also note we did not adapt. So we did not adapt any fractions. It's a pure test of margin reduction. So looking at the patients we enrolled on this study, you can see for the first 100, pretty well balanced. I'll point out, indeed, most of these patients had more aggressive disease. Only about 20% overall had favorable intermediate, so justifying our use of higher dose. There were even some patients with PSMA-defined and positive disease or a high-volume PSMA center. ADT was used as appropriate. Nodal radiation was at investigator discretion in high risk, certain high risk cases, and was reasonably evenly balanced. After the FLAME trial was published in early 2021, we did incorporate a Zental SIB boost. More patients in the final analysis will have had that. We went to 42 gray to the MRI-defined lesion. Spacer was used as indicated and available. A little bit more spacer use in the CT arm. Prior procedures were allowed. We stratified on the basis of gland size and IPSS, so those are kind of well balanced there. And we accounted for urinary meds at baseline as well as baseline GI comorbidity, as you can see. So without further ado, those advances here. Sorry, it went too far there. So the primary analysis outcome was clearly positive. So if you look at the percentage of patients experiencing acute grade 2 or greater GU toxicity decreased from 47% to 22%, p-value 0.01. So clearly positive. And I would say right here, we can make a couple points. So the The first is someone could say, well, that's a very high toxicity rate in the CT-guided arm. You had hypothesized 29%. And I'd go back to the fact that, yes, we based that off of PACE-B and some US trials that used a PTV dose of 36.25. We treated to 40 gray. If you look at, for example, any of the Breaky-Boo studies, this is more akin to that. This is a whole gland high dose escalation where, even if you assume an alpha beta of 2, you're going from like 74-ish gray to 88 gray. So it's expected that this number would have been higher than 29, and that's why we did an interim analysis. Another way of thinking about that is, despite that big dose escalation, this number is not particularly high. It's actually lower than what it was in the PACE-B trial with 36.25. It is a little bit higher than on the VOMC trial, which was 36.25 adapted with urethral sparing, but it's not particularly higher. It's 22%. And perhaps more importantly, if you look at GI toxicity, there was 14% on the CT arm and 0% on the MRI arm. And so GI toxicity is pretty uncommon. Powering a trial to have detected this based on our hypothesized effect would have required a giant trial, but it ends up that we didn't need that. So sometimes just anticipating, criticism, people say, oh, it's an underpowered study. It wasn't underpowered. We found the effect we were looking for was bigger than we thought, and we found it clearly. Not an underpowered trial. In terms of patient-reported outcomes, in terms of kind of IPSS, we looked at this kind of comparing at 1 month versus 3 months, and you can see that the median increase in IPSS was significantly higher, and that's on the left there for patients getting CT-guided treatment. That difference did dissipate at 3 months, which is kind of expected. One, the tincture of time as acute toxicity kind of improves, and two, we are treating patients that develop side effects. If you also look at the percentage of patients with an IPSS increase of 10 or more, that was significantly higher on the CT arm as well. That difference did disappear at 3 months too, but you're talking about 50% of patients had a pretty big increase on the CT arm, whereas only about 1/5 on the MRI arm. Similar pattern with bowel toxicity. So if you look at epic bowel domain changes, a median higher with the CT guidance, dissipating at 3 months, again, because of intervention and tincture of time. And on the right, the percentage of patients with an epic bowel domain change greater than 6, and to be clear, these are decrements in the epic score, right? It's about 50% of the CT arm versus 27% of the MRI arm at the 2 month mark. At the 1 month mark, that dissipated at the 3 month mark. And so overall, I think we can conclude that MRI guidance was associated with a significant reduction in acute grade 2 or greater GU toxicity, significantly larger than hypothesized, allowing a 50% reduction in our required sample size. So we had thought we needed 300 patients, but after this result, we could repower it to 154 patients. And I would, again, as I mentioned, note the high rate in the CT-guided arms to be contextualized with the known increase in toxicity with dose escalation. We went from 36.25 gray to 40 gray. You'd expect more toxicity. Significant benefits in GI toxicity and patient-reported outcomes related to bladder and bowel function were seen as well. There was no GI toxicity grade 2 or greater in the MRI arm, and I would note that has not been reported in any large SBRT trial or series, despite higher doses used in the Mirage trial. And as I mentioned on repeat power calculation, we needed only 154 patients. The way this was done, we needed to wait until 3 months to analyze this primary outcome. So we'd actually already enrolled 156 patients by the time that we did the interim analysis. So we immediately paused the trial, closed it, and are looking forward to publishing our primary outcome analysis by the fall of 2022. I can say that our standard is now to offer MRI-guided SBRT for everybody. Again, one other thing I mentioned it in passing, but to highlight is that we did not adapt. So this was margin reduction only. A separate question is, could you further improve these results by adding adaptive radiotherapy. There will be multiple dosimetric analyses from this trial and things looking at prostate swelling. As we were cases, we did do a subset analysis of that. I was posting a Green Journal earlier this year that did show that there is prostate swelling that's largely accounted for in the margin, but seminal vesicle rotation might be an issue, particularly if you're treating aggressive disease. I do think personally there may be an advantage to doing adaptive radiotherapy as well. If you're trying to do a hypoflame type regimen with an SIB and you're dealing with prostate swelling and then the lesion may or may not be swelling, I think certainly this provides baseline rates to compare against, adaptive radiotherapy, but want to be clear that this trial did not adapt. So it's truly a measure of the aggressive margin reduction. Again, a feature of the trial, not a bug. I'd like to thank, GenesisCare for the invitation, my team at UCLA ViewRay, and specifically Dr. Steinberg and Dr. Cow from UCLA. Thank you very much. And please email me if you have any questions, as I may or may not be able to stay for too long after this episode.
Thank you, Amar, for that truly fascinating presentation. The data you presented is really very compelling. It'd be great if you could stay with us, but I understand you're busy, so we'll let you go for now. The next talk, the next speaker, I'm delighted to invite to the stage is Dr. Anna Brunziel, who is a radiation oncologist at the Amsterdam University Medical Center in the Netherlands, where she co-leads the MR Linac program with Dr. Frank Lagerwaard. I and a few of us in the room personally owe Frank and Anna a huge debt of gratitude for all the support they've given us over the years. So I'm delighted that Anna will join me on the stage in a minute to talk about MR-guided radiotherapy in renal cell carcinoma.
So good afternoon, everyone. I'm really happy to be here, and thank you for the nice invitation to be here at the GenesisCare Symposium and to present about MR-guided ablative radiotherapy for renal cell cancer. So these are my disclosures. However, is there a reason to talk about radiotherapy in the treatment for renal cell cancer? In the past, 2 randomized controlled trials investigated nephrectomy versus nephrectomy plus postoperative conventionally fractionated radiotherapy. And there was no overall survival benefit when postoperative radiotherapy was added to nephrectomy. Also, there was no overall survival benefit observed when preoperative conventionally fractionated radiotherapy was added to nephrectomy. But the efficacy of radiotherapy is highly dependent on applied doses and fractionation schemes. And there is evidence for increased radiosensitivity when radiosurgery or SABR is applied in the treatment of renal cell cancer or its metastasis. According to the ESMO guidelines, the preferred option for primary localized renal cell cancer is a partial nephrectomy when a tumor is less than 7 cm, a radical nephrectomy when a tumor is bigger than 7 cm. For the high-risk patients or patients that refuse surgery, active surveillance is a good option in frail and elderly patients and when a tumor is less than 4 cm. They recommend other ablative techniques such as radiofrequency ablation, microwave ablation, or cryoablation when a tumor is 3 cm or smaller. However, there is a lack of strong evidence there. And what about SABR? SABR is not recommended, but it says it can be exploited in different clinical situations, particularly for unresectable local recurrences or oligometastatic disease. There are no randomized controlled trials comparing SABR to other ablative techniques. And there was one randomized controlled trial comparing SABR to RFA, but this trial was closed due to a poor accrual. What is the current evidence for SABR in primary RCC. A recent systematic review and meta-analysis of the current literature on SABR for primary RCC was performed by Siva and his team, with the aim to evaluate the local control rates, toxicity, and the renal function. And only publications where SABR was targeting the primary tumor were included in this review. And this resulted in 26 publications originating in 8 different countries all over the world. 15 of them were retrospective and 11 of them were prospective trials. Almost 400 treated tumors were included among 372 patients. Most of them were inoperable or declined surgery. The median follow-up in this systemic review was 28 months, and the median age was a bit more than 70 years. In almost 80%, the RCC was biopsy confirmed, and the mean tumor size was 4.6 cm. Most of the patients were treated in 1 fraction of 26 gray or 5 fractions of 8 gray. The local control rates of SABR are very high and compares favorably to thermal ablation in consideration of tumor size and follow-up duration. The toxicity profile of SABR appears tolerable with very few serious events and also compares favorably to other ablative techniques. A direct comparison of renal function outcomes after surgery or thermal ablation is difficult. However, our results are similar to those previously reported in a large systematic review comparing partial nephrectomy to thermal ablation. It's important to keep in mind that the meta-analysis of Siva and his team comprised older patients with larger treated tumors and also with pre-existing renal dysfunction and other comorbidities. So based on, among others, the results of this systematic review, one could consider SABR for primary RCC in older patients, in patients with significant comorbidity, or in patients with an impaired renal function, but also in patients with centrally located tumors near the renal pelvis, or in larger tumors that are less suitable for thermal ablation. Although there is no direct comparison, SABR outcomes are at least within the range of existing treatment options, and it's a convenient treatment option for the patient. And I think you would all agree that it's worth considering this option in certain patients in view of its high effectiveness and low toxicity. So the next step, how to get SABR accepted as a standard treatment. The argument to not implement SABR as treatment option for primary RCC is that there is no or hardly any clinical evidence, although I just showed you evidence. We need to take a different route. It's important to participate in the multidisciplinary tumor boards, treat selective patients, get their positive feedback to the referring urologists, pool our outcome data, and then they can't get around us anymore. So a part of our strategies should be that we attend and participate in the multidisciplinary tumor board where those patients are discussed. Since start with MR-guided radiotherapy in 2016, the number of referrals for renal MR-guided radiotherapy has increased. However, the clear increase is visible in 2018, and that was the moment that we joined the multidisciplinary tumor board for kidney cancer. And in that MTB, the Amsterdam Renal Cancer Network, we discussed the choice of treatment strategy, and that is dependent on patient and tumor characteristics, as well as patients' and physicians' preferences, And several factors are included in this, such as the local control rate, the residual renal function after a certain treatment, comorbidity. And I think we have to tailor the treatment for a specific patient. For example, we discussed a patient of 75 years with an interpolar RCC of 5 cm and a renal function of 35 milliliters per minute. After a radical nephrectomy, the chance of dialysis is real. So that is not really a good option, I think. A partial nephrectomy was not possible due to the location, and because of the size of the tumor, thermal ablation is also not an attractive option. So this patient was referred to the radiation oncologist for MR-guided radiotherapy. Up till September last year, 74 patients were treated with a primary tumor or a local recurrence. And they were treated in different schemes from 1 up till 5 fractions, depending on the tumor volume and their renal function. So patients were always discussed in the MTB, and reasons for referral were most of the time a high risk due to comorbidity, but also due to the tumor size not suitable for other ablative techniques or due to the location, and sometimes it was patient's preference. Is it moving? Not really. Oh, yes. Yeah, it is? Oh, okay. So here you see what a patient actually sees during treatment. And here you see the whole kidney. Sometimes the tumor is not visible during tracking, and then we use the whole kidney as a tracking structure. And of course, only the tumor with the 3 millimeter margin is irradiated. But in most cases, patients, you can see the tumor pretty nice, and then the tumor is tracked with the 3 millimeter margin. Patients, 64 patients that were treated for a primary renal cell cancer, and their mean age was 76 years. As you can see here, almost 1/3 was in a poor condition. But more important maybe, almost 40% of our patients have a substantial renal impairment with an eGFR of less than 45 milliliter per minute. Their mean tumor diameter was 4.8 cm, and for other ablative techniques, a maximum diameter of 3 to 4 cm is generally used. Sorry. Patients were required to have a pathology-proven RCC or a suspicious renal mass on imaging consistent with RCC. Almost 20% of our patients had a solitary kidney. No local failures observed in this cohort to date. However, only in follow-up imaging was only available in 54 of 64 patients. And as you can see here, stable disease, according to the RECIST criteria, was the most common situation during follow-up. And this is very important to communicate with the referring urologist because before any biopsies are performed. There was a limited toxicity, as well acute as late toxicity. And it's clear that the advantage of this treatment is gated breath hold delivery. And here you see the target volume without breath hold. This is the target volume with breath hold. So these parts of the normal kidney would have been irradiated without breath hold. And so actually what we're doing with treating gated breath hold delivery is a nephron sparing technique. And this is really important since the majority of our patients have an impaired renal function. And this is reflected in the fact that despite high dose irradiation of large volumes, the there is only a modest decrease in EGFR. Here you see the pre-MR guided EGFR, and this is during follow-up, and there's only a modest decrease. Yeah, I would like to show you this case. This is a relatively easy one because it's an exophytic tumor surrounded by fatty tissue. So this is a patient that would be suitable for 1 fraction of 26 gray. This is a kind of a bigger challenge because the tumor is endophytic and surrounded by bowel. However, the volume of the tumor is still small. So I would treat this patient with 1 or maybe 3 fractions of 14 gray. So it's important to create evidence and to treat as many patients with a primary RCC with SABR. And one of the groups that is dealing with that is the IROC. And that's a consortium what is established to harmonize treatment approaches and collaborate in research into SABR for primary RCC. And the next phase, and we're participating in that, is establishing a prospective registry and also provide a platform for future registry-based randomized clinical trials. And I hope soon, for example, a study will be launched where we compare SABR to another ablative technique. And with that, I would like to thank you for your attention.
Thank you very much. Anna, you can go back and then I'll call you back.
Okay.
So our next speaker is Dr. Ben George. He's the lead physicist for the MR Linac with GenesisCare. Ben is central to our MR Linac service and leads on all of our protocol development projects within the network. Ben will take us through some sort of complex MRL treatments with a bit of a twist, I think, today. Thank you.
Thanks for the introduction, Philip. Yes, so I'm Ben George. I'm the lead MR Linac physicist based in our Oxford Centre. I've been with GC for about 3 years and moved specifically for the MR Linac program, and so I've been fortunate enough to be involved in the build, the install, commissioning, service go live, ramp up, and continued service development. And when we launched our service, we broke all our treatments down to 2 classes. We had complex cases and prostates. And sort of inferring there that prostate is the simple workload and therefore everything else is the complex stuff. And sort of revisiting this and reflecting on that recently and made me realize actually maybe it's not so simple. Maybe it's not as simple as prostate versus pancreas. So before I start, just a big thanks to all our clinical team who've had a massive role in obviously helping our service all this time. Yeah, thank you to everyone. So as a sort of overview of our service when we went live, and we started with just a single prostate prescription, 36.25 gray in 5 fractions to the whole of the PTV. And is fairly standard approach here amongst other MRL centres using a 3 mil PTV margin, alternate day treatment, and with a target and OAO of recontouring at each fraction, and then dose reoptimization and using the real-time cine imaging and tracking and gating to enable us to treat those patients really confidently. And over the first 2.5 years of our service, we've treated over 175 prostate cases, and it makes around 1/3 of our workload. And we see some benefit in that. So a bit of a summary of dosimetric analysis from a lot of our cases. On the left-hand side, looking at the change in PTV coverage from the predicted to the reoptimized dose, and you can see that we're consistently seeing an improvement in PTV coverage up to 10% and above sometimes. And on the right-hand side, just an example case study there with the left-hand panel being the predicted dose, the prostate, the PTV, in black, and the high dose region in red there that we want to cover the whole of the prostate. And you can see on the predicted, we're not covering that prostate completely. And the right-hand panel, once we've reoptimized, we have really good coverage of our PTV. And needless to say, this goes while maintaining all of our OAR tolerances. And indeed, on the right-hand image there, you can see that the sparing of the rectum is significantly better in the reoptimized plan. So over time, our prostate service has developed, and we've now got a whole family portrait of prostate prescriptions that we deliver. So moving on from the low intermediate risk, introducing high risk patients as well, with a 40-gray boost into the CTV itself. And in collaboration with our colleagues at the University of Oxford and in the NHS, treating patients along the PACE-C trial as well, which is a 3-dose level prescription with 30 gray to the distal SVs up to 40 gray into the prostate. And re-irradiation cases as well, as was covered briefly earlier, with 3 different ways of delivering that, either 30 gray to the whole of the PTV, or a 35 gray just into the visible lesion, or a combination re-irradiation boost of 30 and 35 gray. And also for our primary prostate patients, we've been looking at the feasibility of delivering that consecutive days with the addition of a spacer. So we've treated some patients on a pilot there, and we're going to review the feasibility and safety of that data. And I'd imagine that will become a standard treatment for us in the not too distant future. So how does our service look now, given all that change? So in terms of prostate primary, we introduced the multi-dose levels from somewhere in 2021, and the graph on the top shows the dark bars being the proportion of the patients having multi-dose level treatment, and you can see that regularly accounts for around 1/3 of our referrals. And as I said a moment ago, the consecutive days data is currently being reviewed for safety and feasibility. In terms of re-irradiation, there's sort of no clear pattern yet of how those referrals come through. Around half our patients have had the whole gland treated. That's whole gland to 30 gray or with an integrated boost, and then the other half are just having that visible lesion. And it might be interesting to see how that plays out in the longer run as it becomes maybe more standard treatment for prostate cancer. And on the bottom right, it's just a summary of our treatment times for prostate cases over the first year and a half, couple of years of our service. We're consistently delivering those treatments in 40 to 45 minutes for these patients. And we've talked a lot about A3i upgrade, and I'm sure that will be even faster when that comes online. And the service continues to develop. So coming soon, integrated boosts up to 45 gray for high-risk patients. So this will be a 3-dose level, 36.25 to the prostate, 40 gray integrated boost in the CTV, and then a 45 gray boost to a visible lesion. This is based on data from the FLAME and HypoFlame trial. So looking for a SIB up to 45 gray, but that's limited on OAR positioning and what the OAR constraints are. So if we're very close to the urethra, for example, it might be possible to achieve that full boost. And the identification of that boost region is based upon multi-parametric MRI or PSMA PET. And that'll be for high-risk patients up to T3B disease. And as standard for all of our treatments, we'll use a 3 mil PTV margin for that because we have the ability to have the excellent image quality, the daily adaptation, and the tracking and gating. But there's some areas of the system that we want to make even more useful as well, that maybe we don't do so much as it currently stands. And that's maybe using the T1 and T2 imaging that the system can give us. So on the left is the planning treatment image we use currently, but we can also acquire, while the patient's in the treatment position, at the time of treatment, T1 and T2 weighted imaging. So it'll be interesting to explore in the future how we can try and make most of that additional imaging in these patients. I just want to present some dosimetric data to show the accuracy and sort of quality of our planning over this time, and how our services has continued to evolve and develop. So the left-hand side here is looking at target coverage of the PTV from the baseline plans. So we know in SBRT treatment, we're often compromised by OAR doses, but we can have increased complexity of our baseline plans to try and maximize the amount of the PTV which is covered despite those OARs. And over time, our team have gained experience and confidence in this planning on the MRIdian system, and we've definitely seen a step change in that baseline PTV coverage. And that increasing plan complexity is balanced out with sort of looking at perfection of the plan, but also being pragmatic. We need to be robust and adaptable. When it comes to treatment onset, there's no point having a perfect baseline treatment plan if, when it comes to daily adaptation, there's nothing you can do if something doesn't quite work. We need our plans to be robust and adaptable. And over time, we've gained confidence in what we can deliver. And we've definitely seen improvement of that over the last 2 years. And we've managed to do that while maintaining excellent plan quality throughout this time. So we consistently meet guidance on the dose spill for the baseline treatment plans, and whilst I haven't shown the data here, we ensure that that plan quality is maintained at all of our adapted fractions. So just maybe there's 4 other ways we can look at the prostate planning and the complexity in that pathway. In terms of contouring and how we define various PTV, optimization structures, things that are used in the treatment plan. For our single dose level prostates, we can often do that with 7 rules. You grow a CTV to a PTV and a PTV to something else and subtract the other thing. We get 7 rules to make all the optimization structures we need. When it comes to our 3 dose level plans like PACE-C, we're looking at 15 rules, manual operations, anything we can do to try and get all those things that we need, so significantly more complicated. In terms of the work that's done in the optimizer itself and the objectives and the constraints to go from to produce the plans. In the single dose level prostate, we can commonly use 6 objectives that need to be set up and optimized for each plan. Whereas the 3 dose level cases, we're looking at more than 10 regularly to set up and adjust, so significantly more complex there as well. In terms of re-irradiation patients, we're going to look at gathering prior radiotherapy data, completing radiobiological calculations, to develop new OAR dose constraints. And there's more complexity in planning again, because each patient is unique due to their previous treatment, the time since that treatment, and how we're treating them now. And so we no longer can use a class solution as a starting point. We have to really start each patient from scratch. And in terms of consecutive days, there's complexity in arranging spacer gel insertions, coordinating with multiple appointments with different departments and outpatients, and also managing disruption to the service. If we have most of our patients treated alternate days, they nicely slot into each other day on, day off, and inserting a consecutive day patient in a busy service can make it difficult with scheduling. So how we manage that is also complex. So in summary, I've maybe just wanted to highlight that MR Linac treatment, simple versus complex, it's not just a matter of prostate versus pancreas. We have a really large and continually growing family of protocols we develop. We're continuously looking to develop our service, new protocols and new features of the system. And all that complexity, we try and front load that into our pathway as much as possible, so that when we come to treat the patients on set, there's a consistent and simple workflow for our on-set team to carry out. Thank you very much.
Thanks, Ben. Can I ask you to take a seat? And Anna, can you come and join Ben on stage? Thank you. Do we have our international speakers still online as well? Are we able to see them on the screen? Maybe.
Oh, it's really slippery.
There's Dan. Do we have any questions in the room for anyone here? Wally.
Yeah, great presentations. Question on your response assessment of renal cell. Do you have enough data and enough follow-up in your work or anyone's work to consider stable disease after SBRT to be a surrogate for a good outcome?
That is a very good question, and that is indeed a challenging challenge in the follow-up of these patients after treatment. The problem is that there is no other imaging, so we do the CT-based follow-up imaging. I was at a meeting last week, and there, because the urologists, they always want a biopsy. And when a biopsy is performed, most of the times there's viable tumor. So they say, well, this is not a good result then. But last week I heard about a study, and there they biopsied 16 patients during follow-up, so after 6 months, after 1 year, and indeed there was viable tumor. However, the tumor cells were not dividing anymore. So maybe that is a kind of a proof that a stable disease can be a success. But yeah, indeed, you're right. That is a problem, and that so during my first consultation, I always discuss this item with my patients, but also with the referring urologist, and I write it down in the letters to the urologist. Also about the enhancement, because with the other ablative treatments. The vanishing of enhancement is one of the most important parameters during follow-up, a successful event. After SABR, the enhancement can stay there for 1-2 years. So that is also a thing that I communicate with the referring urologist. Yeah.
Thanks, Anna. Yeah, I agree. I also have to, I do exactly the same and manage the patient and the urologist's expectation about growth. Is there some data around PSMA?
Yeah, but it's
still a bit
conflicting.
Conflicting,
also.
Yeah. And of course we know from prostate cancer that biopsying prostate cancers years after radiotherapy still yields apparently viable cells. So biopsying after radiotherapy is really not a good idea. Escarlata, you had a question?
Yes, thank you. I would like to know your experience in another location, adrenal lesions, adrenal tumors, because I think it's quite similar to renal.
Anna, do you want to talk about adrenal tumors?
So you mean how we do it, or
well,
what is?
If you think it is a perfect indication for this treatment, also.
Yes, of course. It is. It's kind of comparable to the treatment of renal cell cancer, and the advantage is clear. It's the gated treatment delivery you can offer the patient. So, and if you do that on another machine, you always lose target coverage. Because then you have your ITV and all those things. So for the adrenal, it's the same as for the kidney. It's a very good option. You can track it nicely. So we have good results with
Absolutely,
that.
I agree. And also on the MRIdian, you can identify the small bowel, which is often nearby, and make sure that doesn't get overdosed, but still getting a good dose into the adrenal. So yeah, I think it's an excellent MR-guided SABR target. Any other questions in the room? Vlad?
Great presentations to all of you. Dan, do you think in MRI-guided radiotherapy is the best option for patients that relapse after a primary radical treatment with radiotherapy, because you have adaptive treatments and also you have a very good control of the organ at risk? What do you think now?
Hi, Vlad. Yeah, certainly. I mean, it makes a huge amount of sense. Just if you think about it logically. I mean, obviously, the rationale of any radiotherapy, the core principle is hitting what you want to hit and avoiding what you want to miss. And so the better way you can do, is you want to use whatever you've got to do that as well as you possibly can. And so, for all of the reasons we've said, certainly. Obviously, like I did, there's always this potential issue of not wanting to re-irradiate, whereas I think we're now starting to realise that you can do that. And certainly you want to do that in the most accurate way possible. So certainly from my point of view, it's something that if I'm going to do it, I want to do it in the most accurate way. And so it makes a huge amount of sense. As I say, you can make that argument for lots of things. And in the primary setting, as I said in my talk, you can't unsee what you've seen. And, it's very good in the primary setting, but I would particularly be keen to use it in the re-irradiation setting.
The other thing is, of course, that brachytherapy is an excellent treatment for recurrence, but in the UK we perhaps don't have as great access to brachytherapy for relapse as maybe you do in Spain. I know brachytherapy is quite big there. But although I'm a brachytherapist and I have done relapse cases, I actually still prefer MR-guided radiotherapy because it's non-invasive, and that's quite an advantage. Usually the patients are a few years older than their original treatment. Most of them are in their sort of late 70s, and this is a great non-invasive option. It's an option, but in my eyes, it's beginning to push brachytherapy out of the way. Any other questions in the room, or do we have any questions from the viewers on the internet? Yeah. Okay. In the meantime, can I ask Dan a quick question? Dan, in your experience, what do you find the patients say about the toxicity of MR-guided radiotherapy for prostate cancer? How do they come across about it? How do they feel?
So, it's a good question. I think the vast majority, I have to say that most of them will be relatively surprised. So I think most people, even when you say that the toxicity is going to be low and things like that, they invariably, when I generally see them sort of about 4 weeks after their treatment, and invariably they're fine. But huge numbers of them just are quite surprised that nothing really happened. Interestingly, some of them take that slightly strangely and feel that because they didn't have much in the way of side effects, they're kind of worried as to whether or not it worked, which is a strange concept. I understand it, but the vast majority actually tolerate it very well. I have to say, if people do get any symptoms, it tends to be in the first couple of weeks, or at the end or just after the 2 weeks afterwards, and it's mainly urinary symptoms and some urgency, which generally settles down very quickly. But no, overall, I have to say that's one of the reasons that a lot of people are very keen on it, and why a lot of my patients are push for it, because of the toxicity issues and the general accuracy of it.
Great. Do we have that question from the internet?
Yep. Hi, Philip. It's from Dr. Carla Perner saying, have you noticed any different GI toxicity in the MRL group between spacers and non-spacer patients?
Between what? What between?
Spacer and non-spacer patients.
I don't think we have the data yet. We've had the. Would you agree, Dan? The question was.
Yeah, we've done the 10 patients, but we haven't actually analysed the data yet.
We have, so we can't say. But I think anecdotally, without having the data to hand, the feeling is that there isn't a great difference. That's as much as we can say. But pending the sort of further data, I had a few questions for Amar. Amos is sad that he's not here. Ben. I really like your slide of the family of prostate cancer sort of options that you have. So, given that the next step, the imminent next step is the hypoflame type boost. Well, where do you think we can go after that then? What's the next step beyond that?
That's really interesting. I think using different imaging modalities to identify where the visible lesion is and where to boost is good. My microphone's just died. But potentially looking at how we can boost based upon histology, looking at using the histology data for maybe dose painting within the prostate would be quite an interesting approach, and how we combine that data in with all the imaging we have and get that in a way to treat patients.
Great, thank you. Elena?
Thank you so much for your presentation. Maybe you think the future, because we have to. Thank you. Have you talked about the prostate? I mean, without any surgery? That's not wrong. Now?
Yeah.
Yes.
Could you repeat the question?
Yes. Thank you so much for your presentation. I'm wondering, because you talk about prostate without any surgery, so maybe with this technology, the future could be SBRT in bed prostate.
In prostate bed, yes.
Yeah.
Well, I think certainly it would have been interesting if Amar was still online, because I understand in UCLA they are currently accruing data on 5 fractions for prostate bed radiotherapy. And and again, anecdotally, I understand that it is possible and the toxicities are reasonable. So I think that is something that is coming. But as yet, there's no hard and fast data. And I think similarly, MR is also involved in a trial looking at whole pelvis in 5 fractions as well. So those things are things that are, I think, on their way. But data not yet fully mature, I would say. That's great. If there are no other questions, I think we've kept to time. We're 3 minutes over time. That's not too bad, even for Denmark. Thank you very much, everybody. It's been a great pleasure. Have a good evening.